In this video, we are going to discuss about aortic stenosis. Aortic stenosis means the valve is stenosed. That means that the valve doesn't open properly during the time of systole, so that the left ventricular outflow tract is obstructed. That leads to increased pressure inside the left ventricle. This pressure is essential to pump the blood through this narrow opening. So, in the long term, this increased pressure inside the left ventricle leads to concentric hypertrophy of left ventricles and all the complications develop. So, this is what happens in case of aortic stenosis. Let's discuss that. So, more the number of cause, more prone to regurgitation, more the risk of regurgitation. In case of a quadricuspid aortic valve, the aortic valve is normally tricuspid. If there is quadricuspid valve, 1, 2, 3, it is a tricuspid valve. The semilunar valves, we say that also. So more the number of causes. So if you have a quadricuspid valve, then there is more risk of developing regurgitation, and less the number of causes, more risk of stenosis. So in case of bicuspid aortic valve, there is more chance of developing stenosis as compared to a tricuspid aortic valve. So bicuspid aortic valve leading to aortic stenosis is the most common cause of aortic stenosis in younger population. So in younger population, aortic stenosis normally we see in older population. If you see this aortic stenosis in younger population, then suspect bicuspid aortic valve. And genetic conditions like Turner syndrome, it has two congenital heart abnormality associated with it. One is bicuspid aortic valve, another is coarctation of aorta. So bicuspid aortic valve and coarctation of aorta are associated with Turner syndrome. So it the younger population developing aortic stenosis look for bicuspid aortic valve. This is the most common cause of aortic stenosis in younger population, that is bicuspid valve. So normal valve diameter, aortic valve diameter is 3 to 4 centimeter square. So normal aortic valve diameter is 3 to 4 centimeter square. Normal mitral valve diameter is 4 to 6 centimeter square. Mitral valve is larger in size as compared to aortic valve. Normal mitral valve diameter is 4 to 6 centimeter square, and normal aortic valve diameter is 3 to 4 centimeter square. In case of aortic stenosis, there is degeneration, calcification of the valve leaflet. This due to inflammation, this valve leaflet undergoes fibrosis, degeneration, calcification, and that will lead to incomplete opening of the valve. So here you can see, in case of aortic stenosis, the valve doesn't open properly. So there is a narrow passage, left ventricular outflow obstruction. In case of bicuspid aortic valves, also it is associated with aortopathies. So if you find a case of bicuspid aortic valve, then also screen them for aneurysms and dissections, because bicuspid aortic valve is associated with aortopathies. Mandatory CT angiogram before the valve replacement. So we have to rule out other aortopathies if we find a case of bicuspid aortic valve. And bicuspid aortic valve associated with Notch1 gene defect, and it is autosomal dominant inheritance. It is autosomal dominant inheritance and associated with Notch1 gene defect. So normally what happens? Normally the valve completely opens during systole and closes during diastole. But in case of aortic stenosis, this valve doesn't open completely during systole. That will, if the valve normally opens during the systole, then there will be no systolic gradient between aorta and left ventricle. So during systole, left ventricular pressure is 120 mm of Hg, and aorta pressure is also 120 mm of Hg. There is no pressure gradient in case of it is during systole. But during diastole, left ventricular pressure is equal to 10 mm of Hg, and aorta pressure is equal to 80 mm of Hg. This is during diastole. So during systole, there is no pressure difference between aorta and left ventricle, because the valve is opening completely, so there is no pressure difference. But in case of aortic stenosis, if the valve is not opening completely during systole, the pressure inside the left ventricle will rise. So in case of stenosis, LV has to pump with more force to eject blood through this narrow opening. So stenosis leads to increase in afterload. Stenosis leads to increase in afterload. Pressure gradients widens between aorta and left ventricle. Aorta pressure is the same, but left ventricular pressure rises. Left ventricular pressure rises because left ventricle has to pump the blood through this narrow opening. So pressure gradient widen between aorta and left ventricle, and more the stenosis, more the pressure gradient. So this pressure gradient is a marker of severity of stenosis. More the stenosis, more the valve is narrowed, the more pressure will develop inside the left ventricle. So let us discuss furthermore. So based on the location, aortic stenosis is divided into three types. One is valvular aortic stenosis, subvalvular aortic stenosis, and supravalvular aortic stenosis. So let us discuss first about supravalvular aortic stenosis. Supravalvular aortic stenosis is associated with important syndrome called Williams syndrome. So what is Williams syndrome? This is Williams syndrome. Williams syndrome, we see elfin facies. You see elfin facies, broad mouth, short nose with bulbous nasal tip, cocktail personality, mental retardation, joint laxity. So elfin facies, mental retardation, and the cardiac abnormality most common in case of uh, Williams syndrome is supravalvular aortic stenosis. Supravalvular aortic stenosis is the most common cardiac abnormality in case of Williams syndrome. This was a question which was asked to us in the recently conducted IEP quiz. So in the screening round, in which we are third. So what other finding we see in case of Williams syndrome? We see hypercalcemia. Hypercalcemia is another finding we see in case of Williams syndrome. Name a syndrome in which we see hypocalcemia, that is DiGeorge syndrome. In DiGeorge syndrome, there is 22q11.2 microdeletion, and that will lead to failure of development of third and fourth pharyngeal pouches. That will lead to failure of development of thymus and parathyroid gland. Due to development failure of thymus, there will be decreased T cell immunity, and due to decreased development of parathyroid gland, it will lead to no parathyroid hormone. That will lead to hypocalcemia. So hypocalcemia is seen in case of DiGeorge syndrome, and hypercalcemia is seen in case of Williams syndrome, along with supravalvular aortic stenosis. Other cardiac defects seen in Williams syndrome are peripheral pulmonary stenosis and pulmonary valvular stenosis. So eye problem is satellite irisis, strabismus. So this is in case of Williams syndrome. The AAP recommends annual cardiology evaluation for patient with Williams syndrome. So this is all about Williams syndrome. We see there supravalvular aortic stenosis. So based on the location, aortic stenosis is three types: valvular, subvalvular aortic stenosis, and supravalvular aortic stenosis. Supravalvular aortic stenosis associated with Williams syndrome. It is associated with hypercalcemia, growth failure, and mental retardation, and elfin facies. Subvalvular aortic stenosis associated with hypertrophic cardiomyopathy, and valvular aortic stenosis defect in the valve itself. So I told you left ventricular pressure during systole is 120 mm/Hg, and left ventricular aortic pressure in systole is 120 mm. So there is no difference. But due to this stenotic valve, there will be rise in pressure inside the left ventricle. So based on the severity, we can divide into mild, moderate, severe, and very severe. So mild and moderate aortic stenosis, they present with no symptoms due to compensation. I told you that when there will be increased pressure inside the left ventricle, in the long term it will develop concentric hypertrophy. Okay, in case of pressure overload and volume overload, here both is happening, both pressure and volume overload, that will lead to concentric hypertrophy in expense of cavity size. The cavity size is decreasing, but the muscle is becoming hypertrophied, so it can pump with more force. So in case of mild to moderate aortic stenosis, there is no symptom because there is compensatory left ventricular hypertrophy, so it maintains the cardiac output at the expense of cavity size. So in case of mild and moderate AS, there is no symptom because this left ventricle is undergoing hypertrophy and it is maintaining the cardiac output, so there is no symptoms. In case of severe AS, severe aortic stenosis, there is a risk of sudden death 1%, and aortic valve replacement needed. Symptoms are present. So what symptoms, we will discuss that. Remember that in case of severe AS, this hypertrophy of left ventricle cannot maintain the cardiac output, that is leading to severity of AS, and some other things I will discuss that further. And in case of very severe AS, there is LV failure. So LV failure, we will see the features of heart failure that is seen in case of very severe aortic stenosis. Let's move further. So what is severe aortic stenosis? So severe aortic stenosis, we remember the 40-4-1 rule. 40-4-1 rule. So what is 40? 40 is the mean transvalvular pressure gradient, that is more than 40 mm/Hg. Mean transvalvular pressure gradient, the difference in pressure between left ventricle and aorta. Which pressure is more? Left ventricle pressure is obviously more. So that pressure difference between left ventricle and aorta, mean transvalvular pressure gradient, is more than 40 mm/Hg. The pressure across the valve, the pressure difference across the valve is more than 40 mm/Hg. So this is one thing. Another thing is 4. What is 4? Peak velocity across the valve is 4, more than 4 meter per second. So mean transvalvular pressure gradient is more than 40 mm/Hg. Peak velocity across the valve is more than 4 meter per second, and valve surface area is less than 1 centimeter square. So these are the criteria. If it is fulfilled, we call it severe AS. Severe AS symptoms are present. We will discuss symptoms later on. So 44 rule, 40 is mean transvalvular pressure gradient more than 40 and peak velocity more than 4 and valve surface area less than 1 centimeter square. The normal valve surface area of aortic valve is 3 to 4 centimeter square. Normal valve surface area of mitral valve is 4 to 6 centimeter square. So in case of aortic valve, if it is decreases to less than 1 centimeter square along with mean transvalvular pressure gradient more than 40 and peak velocity across the valve more than 4, we call it severe AS. In mild AS, pressure gradient is less than 20 mmHg, moderate is 20 to 40, severe is more than 40. Mild, moderate, severe, mild. This pressure gradient between left ventricle and aorta is more than 20, moderate is 20 to 40, and severe is more than 40. Now let's discuss about the symptoms. So symptom is, remember, like ASD 532. ASD 532. So what is ASD 532? ASD stands for angina, syncope, dyspnea. ASD stands for angina and syncope and dyspnea. So angina is the first symptom. So why it develops angina? Very easy. Due to LVH, left ventricle is undergoing hypertrophy, so it will need more oxygen. So in case of LVH, there is increased oxygen demand. When the muscle is growing, there is decreased capillary density with respect to wall thickness. The muscle is undergoing hypertrophy, but as related to that, these blood vessels are not growing as compared to the growth of muscle. So decreased capillary density with respect to the wall thickness. The wall thickness is growing, but not many capillaries are growing to supply those muscles. So the left ventricle is undergoing hypertrophy, and that is a risk factor to develop angina itself. In case of angina, valves should be replaced within 5 years. So this is 532 mean. In case of angina, if you see the first episode of angina, first symptom angina, we have to replace the valve within 5 years. In case of syncope, we have to replace the valve within 3 years, and in case of dyspnea, replace the valve within 2 years. So syncope, replace the valve in 3 years, dyspnea 2 years. So what happens in syncope? Syncope means, in case of aortic stenosis, it is a left ventricular outflow obstruction, inability to increase cardiac output during exercise. It is a fixed cardiac output state. So this is a typically fixed cardiac output state. When in a normal heart, if you are doing exercise, the cardiac output increases, but in case of aortic stenosis, this remains fixed. So left ventricular outflow obstruction, inability to increase cardiac output during exertion, that will lead to cerebral hypoperfusion. This cerebral hypoperfusion is the reason for syncope. So syncope develops because due to a fixed cardiac output states in case of aortic stenosis, and that will lead to decreased blood flow to the brain, cerebral hypoperfusion, that will lead to syncope. So fixed cardiac output state which doesn't increase with activity. Normally the cardiac output of the heart increases with activity, but in case of aortic stenosis, it doesn't increase with activity. That leads to decreased cerebral perfusion, which leads to syncope. If you encounter syncope, then the valve should be replaced within 3 years, angina 5 years. Let's go to dyspnea. So we discussed here that is the left ventricle is undergoing hypertrophy at the expense of cavity size. So there is concentric LVH, eccentric LVH in case of aortic regurgitation. So concentric LVH in case of aortic stenosis. So left ventricle becomes stiff. Left ventricle becomes stiff and less compliant. It becomes stiff and less compliant, lead to diastolic dysfunction. So diastolic dysfunction is because this ventricle has become stiff and non-compliant. Systolic dysfunction means the LV is not able to pump. That is seen in very severe aortic stenosis. Diastolic dysfunction means it has become stiff, so it doesn't dilate during diastole. So during diastole, left ventricle has to dilate to accommodate the blood, but here this ventricle has undergone hypertrophy and has become stiff, so it is not dilating during diastole. So that will lead to stiff ventricle doesn't fill easily during the diastole. It will lead to increase in left ventricular end diastolic pressure. If it is not dilating to accommodate the blood, there will be rise in pressure at the end of diastole. That is what is left ventricular end diastolic pressure. So increase in left ventricular end diastolic pressure, that will lead to increase in left atrial pressure. Increase in left ventricular end diastolic, increase in left atrial pressure, that will lead to pulmonary capillary venous pressure, pulmonary capillary wedge pressure. So LVADP, LAP, increase in pulmonary capillary wedge pressure, that will lead to backflow to the blood to the lungs, that will lead to pulmonary congestion and dyspnea. So this is the pathway. So if you encounter dyspnea, the valve should be replaced within 2 years. So these are the symptoms, main symptoms, that is angina, syncope and dyspnea. So angina, we discussed the mechanism. Syncope due to fixed cardiac output state, dyspnea is due to LV increase in LVDP, increase in LAP and pulmonary capillary wedge pressure that leads to pulmonary congestion. That is the reason for dyspnea. So dyspnea is mostly seen in case of exertion, in case of mitral stenosis. In case of mitral stenosis, what happens in case of mitral stenosis? In MS, this mitral valve is stenosed, so it has to pump blood during diastole. So in case of exertion, the length of the cardiac cycle is shortened. If the length of the cardiac cycle is shortened, the cardiac cycle is mostly diastole as compared to systole. 0.5 second is ventricular diastole and 0.3 second is ventricular systole. Atrial systole is 0.1 second and 0.7 second atrial diastole. So diastole is 0.7 second. So if this 0.8 second is lessened due to tachycardia or during exercise, that will affect more diastole. So the duration of diastole is decreased. So during that period of diastole, it was pumping blood to the left ventricle. If this diastole is shortened, then it cannot pump the blood effectively to the left ventricle. Already there is a stenotic valve in case of MS, and it is along with that the diastole is shortened. Now there will be more remaining blood inside the left atrium. That will lead to increase in left atrial pressure, will lead to pulmonary capillary wedge pressure, that will lead to same pathway, that will lead to dyspnea. On the long term, it can lead to changes, hypertrophy of these pulmonary vessels, and it can develop pulmonary hypertension. That is another thing. So this is all about the symptoms of aortic stenosis. So increase in LVADP, left ventricular and diastolic pressure, increase in LAP, and increase in pulmonary capillary wedge pressure. So what are some conditions which can be associated with aortic stenosis, which we have to look for? So atrial fibrillation can be fatal in aortic stenosis because atria contribute 20% of cardiac output. So what happens in case of severe AS? In very severe AS, there is LV systolic failure. The heart cannot pump effectively. If along with that we have an atrial fibrillation. Atrial fibrillation most commonly is in case of MS, but suppose if in AS patient has also developed atrial fibrillation, so fibrillating atria is not pumping into the blood into the ventricle. Already ventricle is pumping less blood due to this left ventricular outflow obstruction. Now preload is decreased because this due to fibrillation, ventricle normally atria contributes 20% of the cardiac output. Already here the cardiac output is reduced. Now the atria is undergoing fibrillation, atria is fibrillating, so this 20% is not coming. So AF can be fatal in AS because atria contributes 20% of cardiac output. So if atria doesn't contribute it, then there will be further decrease in total cardiac output. So atrial fibrillation can be fatal in case of aortic stenosis. Systemic hypertension masks the aortic stenosis because it increases the aortic pressure. So this is the left ventricle, this is the aorta. So systemic hypertension means there is increased pressure here, there is also increased pressure here. Normally it was, if there is no AS, then 120. In case of systemic hypertension, suppose our systemic BP, systolic blood pressure is equal to 160, and here due to stenosis the pressure is increased, it is also 160. So if the systolic blood pressure was 120, then what is here the transvalvular pressure gradient? It is 160 minus 120 is equal to 40, or it can be more than 40. So it is, we can diagnose it as aortic stenosis. But if this patient has developed systemic hypertension, now his systolic blood pressure is 160, and now if we calculate the mean transvalvular pressure gradient, then it is 0. It is 160, it is also 160 due to systemic hypertension. So systemic hypertension can mask the aortic stenosis because it increases in aortic pressure. So to avoid this, tightly control the BP. So if the BP is tightly controlled using medications, antihypertensives, so we can measure the mean transvalvular pressure gradient correctly. If there is systemic hypertension, then there will be incorrect measurement of the mean transvalvular pressure gradient. So left ventricular failure is seen in case of very severe AS. Left ventricular failure is in case of very severe AS. Now an important thing, Hedges syndrome. So what is Hedges syndrome? Hedges syndrome is a triad of aortic stenosis, angiodysplasia of colon, and acquired von Willebrand disease. Von Willebrand disease, we know von Willebrand factor is required for the adhesion of platelet to the endothelium. It normally von Willebrand factor present in the endothelium, it attaches with the GP1b9 of the platelet, and platelet has another molecule that is GP2b3A that leads to platelet aggregation and clump formation. In case of von Willebrand disease, we have decreased these von Willebrand factors. So what is acquired von Willebrand? We know the von Willebrand disease is congenital condition. What is then acquired? It is autosomal dominant. Name only two conditions in hematology that are autosomal dominant. One is hereditary spherocytosis and one is von Willebrand disease. But here we are discussing about acquired von Willebrand disease. So what happens here? In case of severe AS, blood is forced to grow through the narrow stenotic valve. In case of severe AS, this blood is going through this narrow stenotic valve. When blood is going through this narrow stenotic valve, there is a high shear stress. Obviously, there is a high shear stress. Shear stress unfolds the von Willebrand factors multimers. These von Willebrand factors exist as multimers. When there is blood is going through a narrow channel, there is more stress on this blood RBCs or this blood that will lead to unfolding of the von Willebrand factor multimers. Unfolded von Willebrand factor multimers are more easy target for ADAM TH13. Normally ADAM TH13 is present in our blood. Its function is to cleave these von Willebrand factors, cleave the von Willebrand factors or break the von Willebrand factors. When they are become unfolded due to the shear stress, due to severe aortic stenosis, now they become easy target for ADAM TH13. ADAM TH13 now cleaves them more. So ADAM TH13 cleaves the unfolded von Willebrand factors into smaller fragments. So it cleaves the all von Willebrand factors, unfolded multimers into smaller fragments that will lead to decrease in von Willebrand factor multimers. These von Willebrand factor multimers are responsible for platelet adhesion. So if now it is cleaved by ADAM TH13, then there will be large von Willebrand factor will be lost from the circulation. So there will be no platelet adhesion, and if there is no platelet adhesion, it is more prone to bleeding from the fragile blood vessel like angiodysplasia. Then it is more prone to bleeding. So large von Willebrand factor multimers are required for platelet adhesion. Now the platelet could not adhere properly at the site of vascular injuries, bleeding tendency develop. So especially from fragile vessel like angiodysplasia, it is associated to angiodysplasia of colon. Angiodysplasia of colon is a fragile blood vessel. It is more prone to bleed. Along with that, we have acquired von Willebrand disease. Then it is more detrimental condition. So severe AS along with the angiodysplasia of colon and acquired von Willebrand disease is called Headache syndrome. So how will it is present with? If a severe AS present with hematochezia, blood in stool, or in the long term present with iron deficiency anemia, then you can suspect this acquired von Willebrand disease. So ADAM TH13 deficiency leads to TTP, thrombotic thrombocytopenic purpura. So what happens in TTP? TTP there is no ADAM TH13. Now what happens? These von Willebrand factors multimers, they consume all the platelet and clotting factors from the blood, and that will lead to that can lead to, if these multimers become like an emboli, it can cause stroke, and it can also cause bleeding because these consume all the platelet and consume clotting factors. So TTP there is cerebral involvement is common, and case of TTP with and this von Willebrand factor multimers along with platelets, they strike on other RBCs and they break them into cystocyte or helmet cells. So what findings we see in the peripheral smear? Cystocytes. So microangiopathic hemolytic anemia along with CNS dysfunction that can lead to ultrasensorium or stroke-like presentation. It can lead to renal complications and thrombocytopenia. All these things are seen in case of TTP. In case of HUS, there is acute renal failure, thrombocytopenia, microangiopathic hemolytic anemia. HUS is a different game. There is typical and atypical. Atypical HUS is the deficiency of complement factor H, and typical HUS is followed by a diarrheal etiology, commonly due to E. coli O157H7 or Shigella toxin. So that is a different topic. So this is Headache syndrome. It is in case of aortic stenosis. Now what are the signs of aortic stenosis? In case of aortic stenosis, in case of severe aortic stenosis, there is slow rising pulse. It is called pulsus tadus. So pulsus tadus, slow rising pulse, slow rising or pulsus tadus seen in case of aortic stenosis. And there is delayed upstroke, slow rising delayed upstroke. It is in case of aortic stenosis, that is called pulsus tadus. In case of very severe aortic stenosis, there is pulsus parvus et tadus. Very severe AS, we see pulsus parvus attardus, pulsus parvus attardus. It was slow rising pulse, it was slow rising plus small volume or decreased volume, slow rising plus decreased volume pulse due to LV systolic dysfunction. It is in case of very severe AS, small volume plus slow rising pulse, pulsus parvus attardus. Normally in severe AS we see pulsus attardus. So what happens to blood pressure? Now there is pulse pressure is systolic blood pressure minus diastolic blood pressure. So what happens to systolic blood pressure? Systolic blood pressure decrease because there is LV outflow obstruction. So there will be decrease in stroke volume. That will lead to decrease in systolic blood pressure, but the diastolic blood pressure is unchanged. So this pulse pressure becomes narrow. So systolic blood pressure minus diastolic blood pressure, pulse pressure is narrowed in case of aortic stenosis. So normal person who has 120/80 blood pressure, now the pulse pressure is 40, but in case of severe aortic stenosis, this systolic blood pressure drops to 90. Now what is the pulse pressure? It is 10. So pulse pressure is decreased or it is narrowed in case of aortic stenosis, severe aortic stenosis. And JVP is associated with the complete left heart, so it is normal in case of aortic stenosis. Apex. What happens to the apex bit? Outward paced apex due to LVS, heaving apex. Heaving apex is seen in case of aortic stenosis. Heaving apex is in case of aortic stenosis. So heaving apex, that is down and out apex. Outward pace due to left ventricular hypertrophy. Due to left ventricular hypertrophy, this is outward paced. It is called heaving apex. High amplitude and sustained apex. Heaving apex means high amplitude plus sustained apex. You see, when you see the apex bit, it is high amplitude and is sustained for some period of time. It is called heaving apex and it is seen in case of aortic stenosis. Another thing we see here, what happens to heart sound? S1 is normal. S1 is due to closure of mitral and tricuspid valve. It is normal in case of aortic stenosis. What happens to S2? So S2 is due to closure of aortic and pulmonary valves. So here, if the valve is degenerate, then there will be hold the soft A2, A2P2. Then if the aortic valve is degenerate, it is inflamed, then we hold soft A2. In case of bicuspid aortic valve, we hold loud A2 or loud S2. So in case of bicuspid aortic valve, there is loud S2. Degenerated valve, there is soft A2 or S2. The severe AS, we see the reverse split of S2, reverse split of S2. So how it happens? Let's discuss about that. So what happens to S2 normally? S2 normally splits during inspiration. So normally it is S2 is A2 followed by P2. We appreciate this during inspiration. So during inspiration there is an negative intrathoracic pressure that will lead to more blood coming to the heart. So from where blood is coming to the heart? From the right side of heart, the blood is coming from superior and inferior vena cava. So when there is a negative intrathoracic pressure, then the more blood will come to right side of heart. So during inspiration, the murmurs which are present on the right side of heart, their intensity increases. Another thing, because the blood flow towards the right side of heart is increasing during inspiration, and blood flow towards the left side of heart increases during expiration. So during inspiration, the blood flow towards the left side of heart is increased. So that will lead to what happens normally. It is A2 P2. A2 aortic valve, it closes earlier than P2 because it ejects the blood in less time. Now there is, during inspiration, more blood is coming to the right ventricle, so it will take more time to eject. So that's why A2 occurs earlier and P2 occurs later. So during inspiration, A2 occurs earlier and P2 occurs later. We heard it, we appreciate the split because during inspiration there is more volume coming to right ventricle and it will take longer time to pump this blood. So A2 occurs earlier and P2 occurs later. The valve closure of pulmonary valves occurs later because it takes long time to pump the blood, whereas aortic valve pumps easily because the volume is same. But in case of right ventricle, there is more volume of blood during inspiration, so it takes longer to pump the blood, takes long time to pump the blood and closes later. So A2 then P2. So this is normally what happens. But in case of aortic stenosis, the valve is so stenosed, or the valve is so narrow, that it is taking more time to pump the same amount of blood. So normally A2 P2 was happening. Now it is taking much time to pump the blood, because the outflow tract is narrow. So the left ventricle is taking more time to eject the blood. Okay, so A2 is coming here. This is what is called reverse split. Reverse split means the split is heard during expiration. Normally the split was heard during inspiration, because during inspiration there is more blood coming to right side of heart, and that leads to delayed closure of P2. But what happens here? Reverse split means the split is heard during expiration and absent in inspiration. So in aortic stenosis, I told you, due to left ventricular outflow obstruction, the aortic valve closes later, because it takes more time to pump the blood due to its narrow outflow. So A2 is delayed. Now what happens during inspiration? During inspiration, P2 is also delayed, because there is more blood in the right ventricle. So P2 is also delayed. Now normally A2 P2, here during aortic stenosis A2 is delayed, but during inspiration there is more blood in the right ventricle, that leads to delayed in P2. So A2 P2 move closer during inspiration, so you can't appreciate the split during inspiration. But during expiration, P2 is remaining here. In expiration, I told you, more blood comes to the left side of heart. So along with that, this patient has aortic stenosis, so it will take more time to eject the blood. So A2 is delayed, much delayed. So you can appreciate the split during expiration. So this is what written: split is heard only during expiration and absent in inspiration. In severe aortic stenosis, LV has to eject blood through the narrow channel. LV ejection time is prolonged. Aortic valve closes later than normal, so A2 is delayed. Then P2 followed by A2. A2 is delayed. P2 followed by A2. So during inspiration delayed P2 also. Since P2 moves closer to already delayed A2, the split is narrows or disappears. In aortic stenosis, A2 is delayed, but during inspiration P2 is also delayed. So A2 P2 move closer, so the split disappears. But during expiration, P2 occurs earlier, but A2 is more prolonged. So the split is better appreciated during expiration. That is what is called reverse split. Normally split heard during expiration. Reverse split means split heard during expiration, not during inspiration. So P2 occurs earlier. Again, while A2 remains late, split becomes audible. So what happens? What is S3? S3 is the sound of failing heart. So when the heart is failing, then we heard the S3. And S4 heard when atria is pumping blood against the stiff ventricle. We discussed here in aortic stenosis, the ventricle is less compliant or becomes stiff due to left ventricular hypertrophy after some time of developing AS. So due to LVS, decreased LV compliance, LV becomes stiff. That's where we heard the S4. So S4 is only heard in all the valvular heart disease, MS, MR, AS, AR. Only in AS we heard S4. It is not heard in MS, MR or AR. S4 is only heard in what? AS. S3 is the sound of failing heart. It is heard in very severe AS or heart failure. So S4 is atrial contraction against stiff ventricle. So it's stiff ventricle present here due to hypertrophy. So S4 is heard in AS. So what happens? Now discuss what happens to the all cardiac outcome. S1 is normal, and S2 reverse split can be there in case of severe aortic stenosis. S3 can be there in severe aortic stenosis or a failing heart. S4 is there because the atria is pumping against the stiff ventricle. Now discuss the murmur. So what is the murmur? Here the murmur is ejection systolic crescendo decrescendo murmur. Crescendo decrescendo means its frequency increasing, attaining a peak, then it is decreasing. This is what is called crescendo decrescendo murmur. Intensity increasing, attaining a peak, then it is decreasing. So it is heard in systole. So what is the difference between systolic and diastolic murmur? So S1, S2, S1. So S1 is the closure of mitral and tricuspid valve. S2 is the closure of aortic valve and pulmonary valve. So after the closure of mitral valve or tricuspid valve, now the left ventricle has to pump the blood. So this is systole. After the closure of aortic valve and pulmonary valve, the ventricle has to fill So during filling we call it as diastole. So the murmurs which occur during systole we call it systolic murmur. The murmur which occur during diastole we call it diastolic murmur. So during systole means when the ventricle is ejecting blood. If there is stenosis, aortic stenosis, we can hear the murmur. So systolic murmur one is AS. If there is mitral valve is not closing properly, increase in left ventricular pressure, left ventricle is contracting, there can be backflow of blood. If this mitral valve is not closing properly, it is mitral regurgitation. So AS and MR, they are systolic murmur. They are heard during systole or the contraction of left ventricle. When the left ventricle is filling, blood is coming to left ventricle through the mitral valve. If it is stenosed, then it will heard here. Now, if the aortic valve is not closing properly during diastole, then there will be backflow of blood from the aorta towards the left ventricle. So this is happening in diastole or the filling phase. So diastolic murmur heard in case of AR and MS. So MS and AR are diastolic murmur. So this is a ejection systolic murmur because it is occurring during systole. Systole, this blood is flowing through this narrow channel. That is what is creating the murmur. It is ejection systolic crescendo decrescendo murmur. During the ejection of blood, during systole, crescendo means the murmur intensity is increasing sometime, attaining a peak, then it is decreasing. This is what happening here. So it's a mixed frequency sound, best heard in leaning forward position with diaphragm of the stethoscope in setting position. This murmur, AS murmur, has two components. One is high pitch component, one is low pitch component. This low pitch component radiates into carotid. This low pitch component of AS murmur, it radiates into carotid, and the high pitch component radiates to apex. So this is called Galla-Verdin phenomenon. So what is Galla-Verdin phenomenon? In case of aortic stenosis, the ejection systolic crescendo decrescendo murmur has two components. One is low pitch component, high pitch component. The low pitch component radiates into carotid and the high pitch component radiates into apex. When this high pitch component radiates into apex, this is what is called Galla-Verdin phenomenon. So it is best heard in aortic area or second right intercostal space. So second right intercostal space is this is the first intercostal space. This second intercostal space. This is left. This is right. So this is best heard in second right intercostal space. So this here in second right intercostal space, this is best heard, this murmur, because the heart is like this. This is the stenotic valve na. So this is left ventricle, this is left atrium. This blood is flowing through this stenotic valve. That's where we heard the murmur in right second intercostal space or aortic area. This is called aortic area. Right second intercostal space. This is where we heard the murmur. Aortic area of right second intercostal space. In case of mild AS, the peak murmurs occurs early in systole. In case of mild AS, I discussed the murmur is like this only. If it is mild AS, then this peak will occur earlier. If it is severe AS, then the peaks occurs later. So mild AS, peaks occur earlier, murmur occurs early in the systole. In case of, because this is taking longer time to eject, because if it is, as it is severe, it will take longer time to eject the blood, so the peak will be later. If it is mild, then it will take less time to eject the blood, so peak will be earlier. So in case of mild AS, peak murmurs occurs early in the systole. In case of severe AS, peak murmurs occurs later in the systole, because it takes longer time for the blood to pass through the stenotic valve. So when the murmurs becomes louder, squatting or passive leg rest test. During squatting, there is increase in preload, and in case of passive leg rest test, there is also increase in preload. That will lead to increase in loudness of the murmur, and the murmur becomes softer during Valsalva straining. During Valsalva, the blood flow to heart is decreased, or during standing, the blood flow to heart is decreased. That will lead to decrease in preload. So the murmur intensity will decrease during Valsalva maneuver or standing. So investigation. So what are the investigation can be done here? Investigation, we can do ECG. We can see LVH. LVH diagnosed by Sokolov-Lewin criteria. For Sokolov-Lewin criteria, we have to see if it is left axis deviation or not. Left axis deviation is this. There is negative QRS in AVF, negative QR is in lead 2 and positive QR is in lead 1. So this is what is coming here. This is left axis deviation. So negative QRS in lead AVF, negative QRS in lead 2 and positive QRS in lead 1. So what is Sokolov law and criteria? Sokolov law and criteria is S deep in V1 V2, ROF in V5 V6. Sokolov law is S deep in V1 or V2 plus ROF in V5 V6. It is more than 35 mm. So S deep in V1 V2 or ROF in V5 V6 more than 35 mm along with left axis deviation, stamp it as left ventricular hypertrophy. In X-ray, dilated aortic arch of ascending aorta or post-stenotic dilatation. And in echo, definitive diagnosis and the severity assessment can be done via echo. So let's discuss again. Atrial fibrillation contribution of atria to cardiac output is about 25 to 40%. Thus in aortic fibrillation it is fatal in case of AS because the cardiac output is already decreased in case of AS. Now it is more decreasing because the atrial component is diminished in case of atrial fibrillation. In case of systemic hypertension there is masking in severe AS because this mean transvalvular pressure gradient can be recorded abnormal. So in case in systolic blood pressure, in case in aortic pressure, decreased gradient or falsely low gradient, thus strict BP control is needed. Diagnosis by transthoracic echo, look for 40-for-1 rule and angiogram mandatory to rule out atherosclerosis, CT and aortogram, dobutamine stress echo to differentiate between LV failure due to aortic stenosis, mild aortic stenosis with pre-existing LV failure. So dobutamine stress echo can be done to differentiate between LV failure due to aortic stenosis versus mild aortic stenosis with pre-existing LV failure. Low flow, low gradient. Examination of findings: pulse is slow rising pulse. In severe AS it is pulse or stridus, slow rising pulse, peak to achieve late. And in case of very severe AS, pulsus parvus stridus, low volume plus slow rising pulse, peak is not achieved, low volume plus slow rising, it is slow rising pulse, pulsus stridus in severe AS. BP due to left ventricular hypertrophy. In aortic stenosis the systolic blood pressure is decreased because the left ventricular outflow tract obstruction and diastolic blood pressure is normal. JVP is only elevated in terminal patient, it is not relevant, it is JVP is mostly right heart founding. And apex is laterally displaced, it is called heaving apex. High amplitude well sustained apex, high amplitude well sustained apex is called heaving apex in case of aortic stenosis. Heart sound S1 is normal and ejection click, pulmonary ejection click can be there, no mistaken for loud S1. And S2, what happens to S2 is loud in case of bicuspid aortic valve, young population, most common cause of aortic stenosis in young population, bicuspid aortic valve. Soft in elderly due to calcified or degenerated valve, and reverse or paradoxical splitting of S2 is in case of severe AS. And fixed wide splitting of AS in case of atrial septal defect. S3 it is seen in case of failing heart, normal or less than normal failing of a non-completed dilated ventricle, pathological LV failure, very severe AS we see the pathological LV failure we see S3. And S4 specific to AS, not heard in early other valvular heart disease. S4 because left atrium contraction, stiff non-compliant ventricle, so non-stenosis mitral valve. So S4 is present, conditions are non-stenosis mitral valve and hypertrophy dilated left ventricle, no MR or AR. So for S4 to be present, the mitral valve has to be normal. Murmur, harsh ejection systolic murmur in late systolic accentuation, best heard in aortic area during sitting position. There is a second right intercostal space. Mixed frequency murmur, low frequency plus high frequency murmur. Low frequency component radiates to the carotid, high frequency components radiates to the apex. It is called Galla-Verdin phenomenon. So remember, all murmurs in cardiology are loud murmurs except Austin Flint murmur that is seen in case of severe aortic regurgitation and tricuspid regurgitation murmur. So this is all about aortic stenosis. So we'll discuss further this valvular heart disease. We'll discuss about aortic regurgitation in the next video.